Hi, good evening, everyone. It's a pleasure to have you here. And we are going to discuss the INI SS 2023 paper. This is a quick recall, and probably we are the first one to do this from cardiology point of view. So what we are going to do is dissect the paper, and also I'll tell you how you should have approached those questions. More so, we'll also touch upon as to how appropriately those questions have been placed in proportion of what we expected and what we taught. If you go through our video about the preparation strategy, I told you which topics you must focus on. I talked about ECG imaging, X-rays. You got one ECG, you got one X-ray. I told you to focus on JVP. There were two questions on it. I also talked about drugs and important trials. There were questions on that. I also talked about pericardium. Again, there were questions on that. I talked about ischemic heart disease, window period, DIDO time, thrombolysis, how to approach those questions. Again, that was there. So let's, without wasting much of time, let me just take you through the questions and we'll try to discuss as much as we can. So welcome to DocTutorials quick recall session for cardiology 2023. And remember, these are the questions that have been given by students like you. Thank you very much for sharing that with us. We have been trying to compile some of these options, may not be the one that were there. So this is based on recall of a lot of questions and a lot of students pouring in. Sometimes the options may or may not be correct. The question framing also may or may not be the same the way it was, but the gist of the question and the gist of the concept is what we are going to cover today. So the first one was based on clinical scenario, and this was 30-year-old female, abdominal bruit. The keyword is bruit. Lot of students were confused, and they told me, sir, it can be FMD, because in FMD you can get renal involvement, you can get stroke. Important point is bruit. Remember that the FMD does not cause bruit. You get a bruit in a stenosis. Abdominal bruit means aorta arteritis, because it means the involvement of the abdominal aorta. Also, the history of headache, weakness, and stroke would suggest involvement of the arch vessels, and coronary with the LV dysfunction, possibly coronary involvement or myocarditis, would also suggest involvement of panarteritis. So, of course, you had to boil down to two options. One was FMD, other was aortoarteritis. The answer is aortoarteritis. Rarely, as I said, a lot of students were trying to juggle it out and find out, and this is what Brunwald also says, that rarely causes intermittent claudication. But remember, this is intermittent. Most often women are affected, both sex are involved, traditionally known to occur in young women. Recently, middle-aged women are more likely to be reported in Brunwald. In addition, describe involving renal with highest frequencies, but similar involvement of carotid vertebral renal in 65% multivessel. Aneurysm dissecting is present in 40%. Spontaneous coronary is a known presentation of FMD. Most commonly, they present with hypertension, headache, tinnitus, dizziness, which is clinical scenario that may prompt consideration of FMD. So here, couple of things that were missing for it to be FMD were: one, LV dysfunction; two, abdominal bruit. Abdominal bruit is one feature that tells you the involvement not just of renal artery but probably aorta, which you rarely ever get in FMD, and hence the answer for this question is aortoarteritis. So I hope that's clear. There was another question on aortoarteritis which was about the clinical criteria, and if you go through that question on clinical criteria, it will be ample clear that when you're dealing with a patient who's got vessel involvement of the arch, and you also have disorders involving multi vessels including LV dysfunction and history of stroke, you should probably be suspecting aortoarteritis. If this question was to be framed differently, did not have abdominal bruit as an option, just had stroke and no LV dysfunction or renal involvement or renal artery stenosis, then you could have thought of FMD. The next was a very simple, straightforward question from statistics, which I believe everybody must have got correct. How to analyze non-parametric tests to which are not normally distributed. So we know where the parametric and non-parametric. This is the table that everybody just mugs up, and this is the common way of doing it. If your sample is dependent or paired or independent or unpaired, whether the data is parametric or non-parametric. So if you're dealing with a dependent, paired, parametric, you do a paired t-test. That's why dependent or paired, which is paired, is parametric. That's how you remember. And if it's unpaired, you do unpaired t-test. Non-parametric, dependent, paired, you do sign test. And that's the chi-square also. You can non-parametric data, you can do also a chi-square test. And Mann-Whitney is done for independent non-parametric data. So non-parametric data with two groups where you have dependency or what is called pairing, you will go with chi-square test. So that's the right answer, which most of you got right. Cardiac sarcoidosis. What is the investigation of choice was the question. Now, investigation of choice is one way of putting this question. Other question would be sensitive test, specific test, de-diagnostic test. According to the framing, the answer would change because gallium or myocardial biopsy would be the diagnostic test for a cardiac sarcoid. You may have systemic sarcoid, but you may not have myocardial involvement. So if you have a myocardial biopsy as an option, which I'm not sure whether it was there or not, you don't know because a lot of students were confused between PET and MR. Now remember, the patterns of MR are variable across the spectrum in sarcoid. So if you remember mid-wall LGE involvement, you can get that mid-wall LGE, epicardial LGE, as well as global endocardial LGE. All you can get in sarcoid, you can get both. As you can see here, you can have mid-wall in sarcoid and you can have epicardial also in sarcoid. And they all have a differentials with it. So you have differentials in form of mid-wall HE involvement being myocarditis, Anderson Febris, and Chagas, while epicardial you can have myocarditis, Anderson Febris, and Chagas. So that's a sensitive way of picking up cardiac sarcoid, but not a specific test. So framing of the question is key word here. If they asked you sensitive, cardiac MR is correct. If they ask the diagnostic test, it's myocardial biopsy. And if the question was just investigation of choice, then it would come to what's more feasible to do and easily accessible to interpret in a clinical scenario a case of cardiac sarcoid. So in which case you can still choose cardiac MR because that's easily accessible. PET is not easily available. Gallium again has its own limitation. Myocardial biopsy may not be easily available in a clinical scenario. And of course, this is from Brunwald's diagnostic algorithm of cardiac sarcoid. You can see an unexplained second degree or third degree AV block, young adult, and or sustained monomorphic VT in the DCMP. CT you rule out to do for a cardiac pulmonary sarcoid and a cardiac MR or FDG PET for cardiac sarcoid. So again, looking into this clinical scenario, if you don't have a biopsy proven extracardiac sarcoid, you need to suspect bundle branch block or second, third degree AV block, VPCs, RWMA, EF less than 50, one or more of out of 5. Again, you proceed to advanced cardiac imaging using cardiac MR or FDG PET and suggestive of cardiac sarcoid. Then of course it's there. If it's no, then you will just do monitoring in a patient with extracardiac sarcoid. So it's important to know whether the patient's history mentioned whether the patient had extracardiac sarcoid or not. If it is not specified, then you will stick with CMR because it's easily accessible, it's sensitive, a high probability if you get, then of course you need to confirm with a endomyocardial biopsy. So the diagnostic test or confirmatory test or gold standard test is cardiac biopsy, but in a sensitive test or a screening test or easily accessible test or the first step in test would be a cardiac MR between the choices. But remember, as I say, when you're giving these kind of options, you need to frame the question properly. Another question was acute STEMI in a remote primary health center with window period of 6 hours. Now remember, this we have discussed ample amount of times. This question has been framed repetitively in our grand test, all India ranking test, QBank series, module test, that it's important to realize DDO time, door in, door out time, and what center the patient is reaching. Now, keyword again here is remote PHC, which means remote would mean that you cannot probably reach a cath lab enabled center in time. So when you have a patient who reaches to you at a remote PHC, and it's likely that the time that you would have to transfer this patient is going to be more if you, and again the other point is remote PHC, what are they accessible to? You don't have TPA available as per the current strategies in those center. Right now what you have is streptokinase. So you'll have to stick to, if you're, this probably was intended to be shared in a format that people who have already worked or looked or observed a PHC or a CHC would know what is available there, and that is streptokinase. So streptokinase was the right answer. If you chose TP or a primary PCI, it may still not be feasible into a huge extent. Statin or GP2B3A was the fourth option, which you can choose out of. STMI patient, candidate for perfusion, FMC to device time less than 90 minutes, non-PCI enabled, DDO time less than 30 minutes. This is only if you can liaise with TPA, but in those centers where you don't have, especially you want to keep it less than 120 minutes, which is difficult for our setup, and transfer to angiogram time, part of invasive strategy, 3 to 24 hours is class 2 evidence. That's where most of our patients would fall into. CTEP, there was a question. All are true except, I think most of you got it right. Primary management is not medical management for a massive CTEP symptomatic patient. The symptomatic patient where CTEP, this again framing is important. If you have a patient of chronic thromboembolic pulmonary hypertension, of course, apart from lifelong anticoagulation, you would look at for the operability, especially in patients whether it's a proximal or distal. PVR is more than 12 Wood units, right heart failure, functional class 3, 4. So it would depend again how the question is framed. If you have asymptomatic, no heart failure, CTEP, of course, its primary management is medical management. The question framing is important. 2 to 4% of them have acute PE, which means as a chronic PE, also superseded by acute PE. VQ scan is more sensitive than CTPA, which is correct, because combining intermediate and high risk Ebstein results in the sensitivity of VQ of CTEP to be 100% and 86% to 90%, and hence it's better than CTPA to look for a VQ. So primary management in a patient who is operable with an endarterectomy is the therapy, and then only if he is inoperable, then he gets therapies like Riosigua, which is the proven therapy in CTEP subgroup of patients, plus along with balloon peripheral angioplasty. So pure medical management would not go unless you have a patient who's falling into the exclusion criteria from this algorithm. Next question was CEAP classification. This, I think, is one of the tables which we have already covered in our diagram table flowchart revision from Harrison. The videos are there. You can go through, and I hope you looked into that. CAP classification is one of those tables from Harrison, which talks about C for clinical manifestation, E for etiology, A for anatomic distribution, and P for pathophysiology. I've included C here. C means no visible signs of venous disease. C1 is telangiectasia. 2 is varicose vein. Recurrence is called a C2R. Edema is 3. Secondary venous disease with sub-Q changes is 4A if you have pigmentation. Lipodermatosclerosis or atrophy is B, and coronaphlebitis is 4C. 5 is healed venous ulcers, and C6 is an active venous ulcer. Recurrent would call as C6. So based on presentation, etiology, primary or secondary, anatomic distribution side, whether it's and pathophysiology, whether it's a incompetence of regurgitation, etc., you can again further classify. So basically it's a classification of venous insufficiency. Most of you got it right. So chronic DVT is where you use a CEAP classification. I think there was another question which they talked about in a case of narrow QRS tachycardia aborted with adenosine, and it converts to sinus rhythm. They did not mention AVRT or AVNRT as an option here, because we all know that AVRT, AVNRT would of course convert, but PJRT is a type of AVRT, and that's why they gave you an option of PJRT. So even if you knew classification of AVRT, AVNRT, PJRT would be the choice of understanding and taking this question. Atrial flutter, atrial tachycardia, and sinus tachy would slow down, but they will not disappear, as you know, with the adenosine infusion. So when you give IV adenosine, no change in rate, you know it's either VT or it's inadequate dose. Gradual slowing and re-acceleration happens in atrial tachycardia, junctional tachycardias, or sinus tachycardia. Termination is a feature of AVRT, AVNRT. Persistent tachy with transient AV block is atrial tachycardia. Only in a PJRT, you would have a conversion to sinus rhythm, and that's why correct option was PJRT if the other three options were the one that I've included here. So that was a a relatively simple question. But PJRT, they persisted with, they asked you a couple of more questions. One was, it's a type of antidromic tachycardia terminated by adenosine and less frequent cause of cardiomyopathy and commonly seen in elderly. Now, this is a interesting question. A lot of important learning points from this question. It's AVRT, as we've already discussed. Very important. It gets terminated by adenosine. Of course, it's orthodromic AVRT. That's why it's narrow complex. It's not antidromic. So that was incorrect. Terminated by adenosine, we just discussed, but it's actually a very common cause of cardiomyopathy. Almost 20 to 50% of the PJRTs can present with cardiomyopathy, and it's commonly seen in relatively young patients, not elderly. And hence, of course, you know the diagnostic criteria of the same. It's one of those long RP interval tachycardias with RP being more than PR with 1:1 AV ratio and inverted P in the inferior leads. That's how you pick up a PJRT. So most of you got it right. It gets terminated by adenosine. There was another question of role of NOACs in RHD versus role of VKA, and I think everybody got it right. The other options we were not able to recollect because this was a relatively straightforward question. We know in which patients to give and not to give VKA or NOACs. VKA are better than NOACs because it's contraindicated. NOACs are contraindicated in mechanical prosthesis, mitral stenosis, especially severe ones, other native valvular heart disease like severe aortic, mild to moderate aortic stenosis or MR, aortic stenosis of severe etiology. Data is again not very much available. Bioprosthetic valve, after more than 3 months post-operatively, you can choose. So it's true for post-operatively, except for rheumatic mitral stenosis. And for patients for mitral valve repair after 3 months, we have very limited data post-TAVI, and also patients may be eligible for an HOCM post-ablation or post-surgery in AF. Otherwise, these are some of the areas where VKA, which is warfarin, is better than NOACs. So most of you got this also right. I think this was a pretty straightforward question. There was not much to discuss in that. This was another question. Again, there was some confusion. Some of the students were wondering. I think this was, if the question is the way it is recollected, what would have been important is to know when the atrial fibrillation patient is undergoing PCI. That is how the question. What you should probably could have thought of is whether the patient had high bleeding risk or low bleeding risk, plus whether the patient had ACS or no ACS. But because the question is framed in a fashion that patient is undergoing PCI right now, it doesn't change. So a lot of students had texted me and asked me whether it's an ACS or not ACS, whether it will change if high bleeding versus no bleeding. It won't, because a patient of AFib is going for PCI at the point of view. At that time, what are you going to choose? So that's pretty clear. You choose triple therapy. There is no confusion about it. So patient has to be on DAPT and NOAC. So at the time of procedure, it is DAPT and NOAC. Difference lies beyond a month. So at 1 month in patient who are high bleeding risk, you go to dual therapy. You can stop it at 6 months and come on to single therapy. Usually it's clopidogrel along with aspirin and a NOAC. So that's the algorithm, and most of you got it right. So P2Y12 NOAC, VK DAPT, or P2Y12 VK were not the right options. Correct option was DAPT with NOAC. Let's move to the next question, which was again on NOAC. Continuing with the NOAC, the question was about dabigatran. Again, most of you got it right wonderfully well, because they had just put a 0 behind 6% bioavailability of dabigatran to make it 60. So 60 was wrong. Dabigatran's viability is poor 6%. And edoxaban, of course, was dabigatran renally excreted, rivaroxaban excreted by both. All options were correct. Bioavailability, remember, it's dabigatran is the direct thrombin inhibitor, 6% bioavailability, 80% renal excretion, oral prodrug converted in liver, peak to concentration time is 0.5 to 2 hours, half-life of 11 hours with duration effect lasting for 22 hours. So that was about pharmacology of dabigatran. There was I have deliberately skipped on medical questions because Dr. Rahul Rajiv has covered most of them. A lot of questions were common between various specialities. So our medicine faculty is going to take care of the questions that belong to general medicine rather than cardiology. And that's why I want to dedicate this recall session primarily to cardiology. But one interesting question on IBD, safe drug in pregnancy, I did not exclude, was STEMI, which is the right answer. Another question was again a clinical question. A lot of people got confused. There was nothing to get confused about. Some said THR is not achieved. Others said RBBB is pre-existing. Remember, it's in LBBB that you don't do a treadmill. RBBB is not a problem. Again, in RBBB, if you're getting 2 millimeter ST depression at 6 minutes and the patient has to stop, and you need to calculate Duke treadmill score. Now, Duke treadmill score is based on a simple formula where you have duration of exercise minus 5 times minus the ST depression and plus the angina index. So when you look at this, you calculate it, it will come to 6 minus 2 into the depression that you had 2 into 5, and angina index of, because he stopped, it will be 2. So this is probably coming right from there. This question was probably picked straight away from one of the task force slides from European Heart Journal in 2005. If you look here, they have put the same values probably here. And it's simple that the score would be less than minus 11. It will come to minus 12. So it will be 6 minus 2 into 6, which is 12. And you stop. So 4 into 2, which is 8. So this will go something like minus 12. So the answer would be less than minus 11. So the Duke treadmill score was to be simply calculated. It surely can be determined in presence of RBBB. You may not achieve THR is not the criteria. THR will of course not be achieved when patient gets an excruciating angina and has to stop exercising. So this answer would be less than minus 11. And as you know, if it's less than minus 11, 1 year mortality reaches up to 5%. Next question was on continuous murmur, which is not seen in. Again, this was more of a hemodynamic question. When a rupture of sinus valsalva takes place to LV, the gradient between the systole and the diastole, of course, when the LV and diastolic pressure will rise, between the the aorta and the LV would not be continuous, because at the end of the diastole and the spilling into the diastole and the end of the late systole, the pressures would actually become equal, and you may have actually not even a pansystolic murmur. So RSOV to LV, because of lack of gradient, will not give rise to a continuous murmur. Other questions were straightforward to choose from, that the other options were of the continuous murmur. Another interesting question, this was from Ebstein's. I usually say that in congenital heart disease, in complex, you can be asked either of the two. One is Ebstein's and other is tricuspid atresia, because these are the two conditions where RV is barely involved, and most of the questions would be dealt with in the dominant LV physiology based on these two pathophysiological disorders. So Ebstein's anomaly, as you know, there is tricuspid valve which is displaced towards the RV cavity, and hence you have an atrialized portion of RV. And because it's an atrialized portion, electrically speaking, pressure wise speaking, this murmur would not be pansystolic. The murmur usually is short systolic, because the regurgitation is happening between RV proximal and RV distal. So from RV distal to RV proximal, the equalization of pressure is much quicker, because mechanically speaking, the regurgitation and dysmorphic valve, the regurgitation would not be strong enough to continue and have a gradient all throughout systole. So PSM at TV it's not found in Ebstein's. You surely can get not only short PR because of accessory pathway, but some students got confused. They believe that the 40% of the patient have accessory pathway, so the patient would have usually short PR. But in patients who don't have accessory pathway, usually the PR interval is prolonged, and hence prolonged PR is correct. Bizarre QRS is also correct. Tall Himalayan P wave is also correct because of the large RA. What is wrong is a pansystolic murmur at TV. So Ebstein's, you don't get pansystolic murmur at tricuspid valve, you get only systolic murmur. So that was the right option for this question. JVP, as I said, is one of the favorite topics. It would usually come in most of the entrances all across whatever specialty, subspecialty, INI, NEET. You would surely get a couple of questions on JVP. And again, this was proven right. You again got it. It's a high yield topic. JVP, remember, and I have hammered a lot of times to you in a lot of my free videos, our videos on JVP, our lectures on DocTutorials, our WhatsApp groups where we discuss questions. X descent and Y descent, just cram it up if you don't want to go into pathophysiology. Rapid X descent, you get in cardiac tamponade. Rapid Y descent, you get in constrictive pericarditis. So this was same modified question. Instead of rapid Y, they mentioned absent Y. And so you knew it. You don't even have to look at other options. TS slow Y, TS large A, all agreed. But just look at this option, absent Y in CCP. It cannot be true. Absent Y in CCP cannot happen. In CCP, usually you get prominent Y descent, and that is called as Friedrich sign. And hence, that option was straightforward, sure shot, full 100% marks if you knew this basic, crammed up this physiological concept, or not even that concept, just cramming up of that X descent and Y descent and tamponade and constriction. You were bound to get one or the two questions from that. PND, this is pretty interesting. Again, pathophysiology. Remember, anything that obstructs pulmonary flow cannot give rise to PND. PND happens because of interstitial edema. Interstitial edema would require blood to be congested into the lung, flow to be there in the lung. You will not have flow because if there is regurgitation, you're throwing back blood into RA with TR. And if you have stenosis, you get congested features of the RA in the venous side. Pulmonary hypertension, as you know, causes peripheral pruning, vasoconstriction, reactive vasoconstriction, and hence actually there is oligemia in X-ray also, as we know. Hence the congestion in the lung or the interstitium would only happen in mitral stenosis. A PND suggests raised interstitial pressure or interstitial edema and increased wedge pressure. That would happen only in patients with mitral stenosis or left-sided obstructive etiology. So PND, the option, I think most of you got it right, is mitral stenosis. Another question was heart failure with preserved ejection fraction, which everybody got right. All of them are true. BNP is elevated, LA is enlarged, obesity is a risk factor, and we have seen this in what is the new HFpEF criteria. So the HFpEF scoring system that exists, all of these have a scoring point for it, and hence you know that all of them were true. Another interesting question was clinical outcome. Now, every time I tell this to all of my students, always read the question properly. When you think that the treatment of a patient who presents with HFpEF in acute decompensation, again, that was also one of the question, would be IV diuretics. But does it lead to clinical outcome improvement? No. The therapy that has been evaluated and shown to reduce outcomes mean a trial which, like you have emperor preserved trial for as empagliflozin, like you had charm preserved for candesartan. So you have trials which have looked into beta blockers, SGLT2 and ARB in the subset of HFpEF in terms of clinical outcomes like reduced hospitalization, reduced symptoms and improvement. But do diuretics lead to clinical outcome improvement? No, there are not trials. So when your question is framed against clinical outcome in HFpEF, what does not reduce clinical outcome are diuretics. Another question was vericiguat antagonistic action. Serotonin, RAS, CGMP, answer had to be CGMP, though they had mentioned all, because the predominant mechanism of vericiguat is CGMP mediated. Excitation with AF, drug not used. Now, this was, I believe, straightforward. We all know prevention and acute intervention. When you want to give a patient AF, in a patient with WPW or a pre-excitation in sinus rhythm, you want to prevent it. We all know that you can use amiodarone. But when a patient of the pre-excitation who presents with atrial fibrillation, amiodarone can be hazardous because it's more likely to block AV node, and it can actually lead to VF or AF getting with the fast rate across the accessory pathway. So you need to use drugs that block the accessory pathway more than they block the normal conduction pathway. And that's why you have drugs like procainamide, flecainamide, or ibuprofen, which can be used, but not amiodarone. Duke's criteria was question from infective endocarditis. Again, usually you will get one question from IE, and four of more minor criteria as a definitive infective endocarditis was the wrong answer. Minor fever is a minor criteria. One major, three minor definite are all correct. We all know four of more is not the criteria. You can choose five minor criteria, but not four or more minor. Abnormalities in heart failure, you would get ascites, you would get hepatomegaly, you would get IVC distended, but you would not get aortic abnormalities, and hence this was a straightforward simple question. There was an X-ray which people thought was looking like this: 20-year-old female, class 2, enlarged RA, RV, MPA dilated, increased pulmonary blood flow. So if that was how the X-ray was looking at, then it was surely a large ASD. If you had DT aneurysm, severe TR, or pericardial, you'll not have increased pulmonary blood flow. So people have told me that it looked like increased pulmonary blood flow. So if your X-ray looks like something like this, you're surely dealing amongst the option. The only option was an ASD. COVID association, I don't know what the other options was, but yes, surely it causes type 2 MI. You've seen a lot of young patients who had COVID, come with fever, have ST elevation, biomarkers elevated, you do an angiogram, and coronary is a normal. So type 2 MI was surely associated with as an ACS presentation in COVID-19. Another question was about bempedoic acid. I think myalgia is more common than statin, should not be correct, but I believe it was gout. So gout is surely more common. It's a prodrug and it's used in statin intolerance. But the option which was surely incorrect was increase in LDL receptor. It does not. It basically is an ATP citrate lyase inhibitor, and hence it's basically preventing the conversion and production of cholesterol at a step higher than the HMG-CoA reductase inhibitor. So it reduces the occurrence of acetyl-CoA in liver, and hence the HMG-CoA production is reduced. And this on top of when the statins are given or not given, you can actually have LDL reduction, irrespective whether you've given statins with bempedoic or not given, this drug would lower. So myalgia, if it was given, I don't think that was the right option. But I think some people have remembered maybe incorrectly. Gout was more common than statin. Yes, it was found it causes hyperuricemia in some patients. Tendon injuries, tendon ruptures are more common. Myalgia may or may not be true. Myalgia is not the right option, but I think they had given tendon rupture and gout, then probably it was correct of the framing of that option. So, but surely increase in LDL receptor cannot be true. Another interesting question, glulysin was asked, short-acting insulin. I'll just skip it for the medicine team to take it up with you, or our endo team to take it up with you. Cardiac tumors, again, I always say it's a high yield topic. You'll always get one question. Our cardiac tumor chapter on the video is free for all. You can always go and listen to that video. It's free for all. It's a very elaborative video. I've covered everything that you can have, including from Brunwald's and the recent updates. Cardiac tumor chapter, you will always get at least one question. Again, in this INI, you got one question. All are true. Except, so fibroelastoma is not the most cardiac tumor. It's a myxoma, which is the most common cardiac tumor. Rhabdomyoma in children and secondary malignancies are more common than primary is also correct, because you are more likely to have metastatic malignancies reaching the heart through the IVC or by the nearby structure through the invasive etiology into the pericardium, rather than a primary of the heart developing, and that option also was correct. Another question was on free wall rupture in MI. All are true except. Now, one of the options that was incorrect was more likely to happen in second MI, which is not true, because fibrous tissues are difficult to yield through. Muscles are easy to this. Our surgeon friends will tell you that it cuts like a knife through a cheese. That's how bad it is when they are trying to repair a VSR, ventricular septal rupture. So ST elevation, the other features were not shared completely with me, but risk factors of free wall rupture, risk factor of ventricular septal rupture is what something you should all remember by heart. You'll always get one question on mechanical complications of MI, as I always say. So one of the questions this time was on free wall rupture. So free wall rupture in myocardial infarction, all of them are true, except it's more common in the first MI, not in the second MI. Most of these patients don't have an STMI, they have STMI. They have very high necrosis, which means CPK total and MB would be rising drastically. Elderly patients, anterior MI and transmural MI, these are the patients who will get free wall rupture, and usually it's the first massive transmural MI. Next question was mitral stenosis in pregnancy, worsening usually as progression, and gradient worsening without worsening of mitral valve area. I think some of the students were not able to clearly remember, but they were very clear about this option, and most of you got it right, that you don't do BMB before second trimester. It's understood because you don't want radiation, number one, to the fetus before the organogenesis is complete. That's the prime reason. But secondly, most of the deterioration that would happen as the third trimester progresses, the fetal blood increases, as the placental flow increases, and as that progresses, and you don't want the labor and the third stage of labor and the third trimester to be overburdening a narrowed orifice. And that's why most of the time, and the most convenient time, is to go in between the end of the second trimester. You don't do it before, You do it at the end of, or usually middle of the, beyond 20 or 24 weeks is when you plan a balloon mitral valvotomy. So that option was straightforward. Most of you got it right. That's the answer for this question. Strategy to prevent contrast nephropathy. Again, I've put on some options. Maybe they are from my own side. I don't remember, but I think again everybody got it right. Hydration is the best strategy of preventing a contrast nephropathy. So IV fluids was one option that was mentioned. It's very clearly mentioned to prevent contrast nephropathy. Avoid nephrotoxic drugs, which would include drugs like metformin, ARB, ACE inhibitors, even to some extent SGLT2. Now, you must hydrate them, give IV fluids, good amount of fluids. N-acetylcysteine, phenol-depam, soda bicarb all have failed to yield any good result, but it continues to be used across the spectrum. People are getting an acetylcysteine and a soda bicarbonate, but IV fluid is the only proven correct hydration strategy which can prevent contrast nephropathy. Most of you got it right. There was another ECG where they had asked the culprit vessel. Again, the options might have been filled up or given to me in not proper order, but it was an ECG, as I'm told, of Valence sign or Valence syndrome. And we all know that Valence you get in a proximal LAD, and this is usually a subtotal to total occlusion, 99 to 100% occluded proximal LAD. That's when you get a Valence sign, and that's why the options were amongst the vessels. The right option would be LAD. So in Valence syndrome, the ECG, the culprit vessel is bound to be left anterior descending artery. Another question was on hypertension, again expected to come. 3 drugs of much diuretic, which is the right option. Other options, again, I have not been shared with. But alpha blocker, a drug of choice, is not true. You need to first exhaust the 4 basic drugs, which again would depend on the class of drugs that you're using. So if you've used an exhausted beta blocker, then if you think of in a clinical scenario to add alpha blocker or a centrally acting drug is left to your choice. So there is no drug of choice. You'll have to choose a workup first, decide what kind of a patient it is, and depending on the etiology, you can choose any of the drugs. So there is no drug of choice in resistant hypertension. You can choose beyond the 4 class of drugs or 3 class of drugs once you've exhausted, including a diuretic, as classical resistant hypertension has been defined. Drug contraindicated in pregnancy. I was told it is beta blocker CCB. There's no problem much with the labetalol like of beta blocker. You want to avoid placenta crossing beta blocker to prevent fetal bradycardia. But as a group, beta blockers are pretty okay to use in pregnancy unless it doesn't cause fetal bradycardia. CCBs, of course, we know. Methyl dopa, we of course know. But thiazides have been classically stamped as a contraindicated class C drug in pregnancy. So class C drugs in pregnancy include ibutalide, which was one of the options if it was given, and the other option was, of course, thiazide. Now, between the two, ibutalide, the other question, it's not this antihypertensive drug, ibutalide and thiazide, again, you would stick to choosing, both of them have been categorized as category C, so either of the two, but then thiazides, you would thiazide likes may still sometimes people talk about being used, but thiazide you would stick to because it's the traditional teaching as the drug which is not given in pregnancy. A patient was blood pressure 170/95, initial antihypertensive of choice. See, remember this is more than 20 above the goal, and hence you can directly go with dual drug. Again, between a patient who's to be chosen dual drug, you would choose a drug which is amongst the first 3 lines. So between the combinations, you had beta blocker, which is not amongst the first 3 drugs, and hence the choice would come to amlodipine and telmisartan. So your answer was correct. Most of you again got it right. 2 drugs and to choose between the first 3 lines. Another question was on peripartal cardiomyopathy. All are true except. Now, here they said the most commonly diagnosed in last month of pregnancy. No, most of them come peripartally. Some of them come actually immediate postpartally. So most often the diagnosis is not the last month of pregnancy. Actually, we know that it develops in the last couple of weeks most of the times, though it can happen in the last month anytime, but usually peripartally that you pick up. Multiple pregnancy is of course a risk factor, we know, and there were some other options given which were all correct. So incorrect was last month development of cardiac failure. So this is the classical diagnostic criteria. of peripartal cardiomyopathy within 5 months after delivery, absence of identifiable cardiac failure, risk factor, recognizable heart disease before large pregnancy, EF less than 45, fractional shorting less than 30, LV and diastolic dimensional more than 2.7 centimeter per meter square body surface area. So these are the peripartal cardiomyopathy diagnostic criteria, which have now been updated with some echo findings. This was an interesting question. So you had a question on supranormal conduction in cardiac tissues. Actually, this is from a seminal paper published way back in 70s, from which this article, which I have shared in the WhatsApp group, you can go this 25-page long article I've shared in the WhatsApp group that we have, where our students keep learning on daily basis, where I try to share something. So in that article, if you go through, you'll see that only 25%. So what is supernormal conduction? Supernormal conduction doesn't mean that it's conducting too fast. It simply means that the conduction is happening at more than anticipated velocity, whether it's diseased or healthy tissue through through the conduction system. So so they were asking what is true. So not seen in conduction? No, it is seen in actually conduction system abnormality. So that's not true for sure. Purkinje fiber velocity is usually in the range of 2 to 3. So 8 again is not true. Even in the disorder, if the paper that I've shared, you can go through. The two other options are usually left now is the narrow QRS with LBBB. Now remember, this happens in 25%. 75% of supernormal conduction happens with RBBB. And that's one of the mechanisms that people explain for Asman phenomena. But narrow QRS with LBBB can also, you can have 25% presenting with LBBB. Again, the other option given was QRS of less than 100. Now, usually, again, in majority, it would be more than 100 millimeters if you go through again that paper. But if you look at the frequency of both, in up to 50%, QRS can be narrow up to 500 milliseconds. And in 25%, you can have QRS narrow with LBBB. So between the two to choose, by 25% versus 50%, the option would be QRS less than 100 milliseconds. So I've shared that paper. You can go through it. It itself is a big chapter. This was a tough question. If you could not make it out, don't worry about it. This was one of that rare paper, that rare question that can come across in from electrophysiology, that you may just have to either leave or take your basic sciences to its best attempt. Drugs causing hypokalemia was pretty straightforward. I think they asked you torsemide and furosemide was the confusing option. Furosemide was the right, because torsemide in toric study, the mean potassium achieved was 5.2. So it does not, torsemide alone per se, cause hypokalemia, though it's a loop diuretic. Of course, the other options were triamterene or spironolactone. I'm not sure. I filled up the options of my own as per what was shared, but furosemide is the right answer. It is the one that causes hypokalemia. Acute heart failure best treatment. So this is like IV diuretics, though it does not reduce mortality. But again, remember, in acute heart failure, you can't use beta blockers. SGLT2 in acute heart failure, now the data is still coming up. You have some data for impulse, but remember, this is not in the right acute setting. It's in the much later setting at the time of discharge. Earliest studied drug is vericiguat, but that is also beyond 24 hours. So best drug when you're asked when you have acute heart failure, again, they've not clarified whether it's a patient with HFpEF or HFrEF, but what you call as an acute decompensated heart failure, you need to choose diuretic to decongest the patient. Physiological pacing, they had asked the benefits. It was expected either you will get a bundle branch pacing or you can get a CRT based question. But narrow QRS, AV synchrony, all of them were true. So I think most of you got it right. All of the above was the correct answer. Semaglutide, there was some question again, which everybody probably got it right. Heart transplant rejection, routine surveillance, all was correct. You need to do cell-free DNA. You need to do endocardial biopsy as a routine annual checkup. First of all, you need to do it 3 times at least. And IVUS you need to do for cave. In patients in the later stage, these patients can end up developing cave, vasculopath, as you know. And that is something that you might need when you're doing an angiogram on follow-up. So all are correct. Takayasu's, they asked you what are that all of them are diagnostic criteria. So modified Sharma is a classification used for involvement. It's not a classification per se, but it's a categorization or grading or type of aortoarteritis, so which is correct. Euler's is again classically known for the ARA criteria. Ishikawa was the original criteria. There is no criteria like NIH, which is used for Takayasu, so that was the incorrect option. So this was the question which I've already covered on the angina. There somebody had mentioned heart rate of 138. So it doesn't matter, 60-year-old or whatever age, it doesn't matter what HR is being achieved because he has to stop. So you can always calculate Duke's score. There was some confusion about an ECG of a wide complex tachycardia with irregularity with heart rate of 150. Now I'm not sure if it looked like this, but if you had a capture beat, remember that in patients with AF with WPW also, you can have supranormal conduction and you can have what looks like a capture beat here, but it's not capture beat. It continues to be a case of AF with WPW with aberrancy. It doesn't make, so don't look at the ECG here with one or the other beat looking like a capture beat. It's simply supranormal conduction and it may actually be nothing but WPW with AF. So don't confuse these with a capture beat and consider it as VT. But I'm not sure what the ECG look like unless I see those images. I'll not be able to comment. But I've deliberately included this image. I've chosen this image here to tell you that you can have an AF with WPW with supranormal conduction looking like a capture beat and still it may not be a VT. It's still so more likely irregular rhythm 150 kind of a heart rate with irregularity and a delta. You should always think of WPW with an AF rather than a VT. Brugada was what etiology, calcium sodium channelopathy, which was everything everybody got right. And one interesting question, I was really happy that somebody was looking at the mechanism, the very basics of LV function, framing this question. A fantastic question. How does the heart contract? So, as you are a cardiologist, you should know that it's like wrenching of a towel. It's a towel twisting. So, you have the left ventricle and you have the LVOT. It the LV is not forcing pumping out like this, not like the clenching of the fist. It twists around its long axis and squeezes. So there are fibers that are there. You have circumferential fibers, you have longitudinal fibers. All of them are contracting, and hence not only it's shrinking its diameter, but it's also moving closer to the outflow tracks. That's why you have the apex that comes and hits your finger and then just goes away. So the slight tapping normal character of an apex is also explained by twisting of a towel, squeezing water out of it, and that's what a normal function of LV looks like. So those were the maximum questions that I could cover. Thank you very much for sharing this question. I'm indebted to most of you students who wonderfully well shared these huge bank of questions with the options with recollection. I will be out of uh, uh, you know options here because it would not have been complete, and if I was to name a couple of you, that would be injustice to some of you who shared individually a lot of questions with me. And thank you for doing that. Because of your trust and faith in us that you could share these questions, I could do the recall session as quickly as I could, as I promised. So thank you very much for staying connected. I can see Raj sharing in the chat box that the fourth option was high dose statin in the question on remote village. That's fine, but as long as you have a patient in a remote village where you have a thrombolysis available as an option, you would stick to it, because remote means the time to revasc is not there. PPA, of course, is not available. I don't think high dose statin should be the right option in this question. So thank you very much. If there are no more questions in the chat box, you can always WhatsApp me personally. You have my number. You're added to the group. You can share your doubts with me, and I'll always be pleased to answer them, help you out to reach your potential and match with what you want to do in cardiology or otherwise. Thank you very much. Have a great day. Take care.
Thank you, doctors. Thanks for the attending the session.